Most people are never told what these tests actually mean or when to ask for them, because knowing your numbers is not about fear, it's about taking ownership of your fertility. This means that we can't just assume it's you or it's him. It really has to be a complete evaluation to get full data. People say things that are really dismissive, or they make a lot of assumptions based on your health or your age. That is just not the case. Welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today I'm walking you through a topic that can feel overwhelming, confusing, and often way too delayed: fertility testing. If you've been trying to conceive, wondering about your timeline, or even just curious about your hormone health, you've probably found yourself Googling tests like AMH, FSH, or wondering what's normal. But here's the truth. Most people are never told what these tests actually mean or when to ask for them. So in this episode, we'll cover what fertility testing includes for you and your partner, what labs can tell you and what they can't, and how to prepare for testing, what questions to ask, and what should happen next. Because knowing your numbers is not about fear, it's about taking ownership of your fertility. And I'm here to make sure that your doctor's visit is going to be informed, you can advocate for your own health, and you know what you're getting into. So let's dive in. When it comes to fertility testing, I often find patients really curious about when they should see a fertility doctor and what needs to happen next. There's a lot of fear that going to see a fertility doctor is going to be really embarrassing or overwhelming, or what if you're going too soon? The first thing I want to cover is just basic education about what we're going to be talking about and what is included in fertility testing and when you should go. Fertility testing includes evaluating both female and male partners. This is because factors that can impact fertility are 1/3 due to female causes, 1/3 due to male causes, and 1/3 due to causes that impact both male and female. This means that we can't just assume it's you or it's him. It really has to be a complete evaluation to get full data. When you should get pregnant is a decision that's up to you, but you can get fertility testing done at any time if you're curious about your reproductive health. It's really important, though, to understand that no test is going to tell us that you are fertile and can get pregnant. The entire point of fertility testing is for us to have an earlier identification of factors that might be preventing you from getting pregnant. This is a huge difference in our mindset because I often see patients say, well, I had that tested years ago and it was fine, so I know that I'm fertile. Very important for you to understand that's not exactly the case. What we're looking for is who needs earlier intervention or who might need help on their journey to parenthood. So first of all, when should you get testing? If you're trying to get pregnant and you're not having success, there are some guidelines about when you should get fertility testing. If you're under age 35 and you've been trying to get pregnant for 1 year, you should schedule a consultation with a fertility doctor. If you're between 35 and 40 and you've been trying to get pregnant for 6 months, then you should schedule a consultation. And honestly, if you're 40 and over, my recommendation is that you just schedule a consult right away. There's no reason to try for any set amount of time. You really want that data in your hand so that if there's a problem, we can intervene and take action a lot sooner in this journey. However, if there's anything abnormal or you're concerned about, you should go sooner than those timelines. Number one problem that I see with patients is an irregular or an abnormal cycle. Understanding your period cycle is key to getting pregnant, and if your period is not coming at a regular, predictable interval, you do not need to wait any set amount of time before you come in and you have testing done. This means go ahead and call the office, get a consultation right away. You also don't have to wait for those time periods. So if you have really heavy or painful periods, if you've had pregnancy losses in the past, if you know you have endometriosis or PCOS and you want to get an evaluation sooner, you absolutely can. I also see patients who are waiting to schedule a visit until their gynecologist brings this up to them, thinking, well, if my OBGYN's not bringing it up, everything must be fine. And the truth is, that's not always the case. Your gynecologist is there for preventive health, to make sure you're up to date on your pap smears, to talk about contraception. And unless you are bringing up your family planning journey, you can't guarantee that they are going to. This means that you have to advocate for yourself and know what's important for you along the way. When it comes to testing, you don't need a referral. Your doctor can send one, but you can just call my office or any fertility office and say, I'd like to have fertility testing done, and we will schedule you. I think it's really important to understand what you're going to do with the information. And I always ask, what's your goal? Because that's paramount to us doing the correct testing and being able to interpret and process that data the best. But you've heard me say it before, you can't make decisions on data you don't know. And I'm a huge fan of early testing. And if our worst case scenario is all the test is normal and you decide to try on your own a little bit longer, you can at least do it with peace of mind that there's nothing else preventing you. When it comes to testing, let's go through evaluation of both male and female partners. So for the male partner, it's pretty straightforward. You're going to have a semen analysis. With a semen analysis, what we're looking for is to get a full evaluation of the sperm. This is going to include the volume of the sample, the concentration of the sperm, the motility of the sperm, and the morphology or the shape of the sperm. The semen analysis is also going to give us information on the pH of the sample, if there's any immature cells or white blood cells. So there is some additional information gained from that sperm sample. But this is the first line test for the male partner. It actually tells us a lot about male hormones because sperm and testosterone are made at the same time. So if your testosterone is low, your sperm count is going to be low. This brings up one really important side note is that taking testosterone for men is essentially male birth control. It tells the brain to stop sending out the hormone signals that make testosterone in sperm, therefore not making sperm. So it's really essential that if you're trying to get pregnant or you want to be pregnant in the future, that the male partner is not on testosterone therapy. This doesn't mean that low testosterone is not a problem, because of course it can be, but there are other safe medication options that will help you boost production of testosterone that do not harm sperm production. When it comes to female factors, there's a lot more that we have to test, unfortunately. So in general, what we're looking for is number one, a really thorough medical history to see if you are ovulating. And what's the best sign that you're ovulating? This is going to be a regular, predictable period. And so we're going to get into the nitty gritty. How far apart are your cycles? How long do they last? Are you tracking ovulation? What are you using? When is it coming? This means you know right away, I'm going to ask those questions. So open up your phone or your cycle tracking app or your calendar and pay attention to the data it's giving you. That way you have it readily available when I'm asking these questions. Number two, if I'm unsure if you're ovulating regularly, if you're not sure if your period is regular, there is testing we can do to confirm ovulation. This is typically going to be done with a luteal progesterone level. Remember that progesterone is made from the corpus luteum after you have ovulated. It's made in pulses, so progesterone's not telling us about the quality of the luteal phase. It's just telling us if you did or you did not ovulate. But it can confirm ovulation if you're unsure if your tracking is accurate. From there, in almost all patients, we're going to draw a blood test called an AMH. AMH is anti-Mullerian hormone, and it's a marker of your ovarian reserve. Ovarian reserve is a fancy way of saying how many eggs that you have remaining. My analogy for this is to imagine that there is a vault inside your ovary, and when you're born, that vault is full. You have all the eggs you're ever going to have. Every single month, you have a group of eggs coming out of this vault, and each egg grows inside a small fluid-filled structure called a follicle. Well, around the follicles are cells that make AMH. In one given month, you're going to have one of these follicles or eggs grow, mature, and ovulate, and the rest of them are going to die. But what's really fascinating is that when you have more eggs in the vault, typically when you're younger, you're going to have more eggs coming out of the vault every month. And when you have less eggs in the vault, you're going to have less coming out every month. So the eggs outside the vault are a surrogate marker representing how many eggs you have remaining. So AMH made from the eggs outside the vault is also representing how many you have. To put it simply, more eggs remaining, more AMH. Fewer eggs, lower AMH. AMH is just a blood test and it's not perfect. It is going to fluctuate a little bit month to month because our body is not perfect. You will have a different number of eggs sent out from that vault every single month. But we're looking at the average to get an idea if you're at your age-related norm or if you might have more or less eggs for your age. Importantly, AMH is not telling us if you're fertile or if you're infertile. Because if we think about it, if you have 5 eggs outside the vault or 20, as long as you're still ovulating, you're ovulating 1 egg. So you have the exact same chance of getting pregnant as somebody who might have a higher or lower AMH. However, you will have a shorter reproductive lifespan. you'll go into menopause earlier, and this severely could impact your reproductive goals and your timeline. In addition, women with a lower AMH are going to get fewer eggs per cycle of egg freezing or IVF. Because when we do those treatments, what we're trying to do is get all of the eggs outside the vault to grow. And I can only make grow what is there. However, AMH is really insightful to us. And one question I always ask is, if yours is low, why? There might be some common causes that can contribute to having a low AMH that also do cause infertility. Examples include smoking or endometriosis. So it's not quite as simple as saying, oh, AMH doesn't impact your fertility, but it might not prevent you from getting pregnant, and it might not be the cause of infertility if you are having trouble. In addition to the AMH, we like to do an ultrasound determination of your follicles. This is called an AFC, antral follicle count. Honestly, what we're doing is we're looking with vaginal ultrasound so that we can count the small follicles that are outside the vault. We can actually see them. This number also fluctuates month to month, but it's giving us an idea between your AMH and your antral follicle count where you are on this reproductive timeline. And I think that's really important and insightful information so that you can make the decisions that are right for you. Now, if your period is irregular at all, or if it's absent, there's going to be some additional tests that we're going to want to run. Basic ones are hormone panel tests, including a thyroid level, a prolactin. If you are not having a period at all, then we're typically going to add in the gonadotropin testing, which is FSH and LH. And we might add an estrogen level to see if your ovaries and your brain are in sync. If you have high androgen levels, which are male hormones, so things like hair growth, acne, then we're going to want to be screening for things like PCOS or congenital adrenal hyperplasia. This is testing with testosterone, a DHEAS level, and 17-hydroxyprogesterone. Essentially, all of this is blood work, but your medical history, what we started with, is giving me the key to know what tests I need to order. And so understanding your own history, your menstrual cycle, and what symptoms may be normal or abnormal is essential for you to be able to relay so that we can order the right tests. From there, we're also going to do an internal evaluation of your anatomy. It's really interesting because we always think about the uterus as this triangle-shaped organ inside of our body because we see it that way in pictures. But the truth is that the uterus is a potential space, meaning I can't see inside the uterus unless I go and I look inside. On vaginal ultrasound, the two walls of the uterus are actually close together, meaning I can't see what's right inside of them. This means I need to fill the uterus, I know this sounds crazy, with saline or dye and push the two walls apart while I'm looking with imaging to be able to see the inside of the uterine cavity. Women can have uterine birth defects. You can have scar tissue, polyps, fibroids, anatomical abnormalities that can make it difficult to get pregnant. And some of these require surgical resection or removal before you'll be able to conceive. At that same time, we can pass this liquid into your fallopian tubes. The most common test to evaluate this is called an HSG or a hysterosalpingogram. This is known as the X-ray dye test. So the dye is going into the uterine cavity and we are pushing it through the fallopian tubes while we take X-ray pictures, getting all of that information if your tubes are open and if the inside of your uterus is normal at the same time. A similar evaluation can sometimes be done in the office with saline or air, called a bubble test or a FemView test, but that is only done in certain circumstances, so not all clinics will offer that. So what we need to do is think about the fact that we're going to have blood testing, we're going to want to do an ultrasound, we're going to do some more extensive anatomical evaluation like an HSG, and we're going to do a semen analysis. I think it's important to add that I'm a big fan of preconception testing in addition. So if you're coming to me with the goal of getting pregnant eventually, we want to consider adding on testing for things like genetic carrier screening, are you immune to rubella and varicella, and important hormone levels like vitamin D, which can impact your fertility. Fertility testing is about understanding egg, sperm, and the uterus. We want to get a full evaluation so that we're not leaving anything hidden. One small miss, such as not checking a semen analysis, might lead us in a position of not having all the information that we need in order to make that appropriate next step. That leads us to our next section. What does fertility testing really look like in the real world and why is it important? I had a patient who was 28 years old who'd been trying to get pregnant for 2 years when she came to see me. She came with a full panel of blood work, an ultrasound evaluation, and an x-ray test. Those tests had actually been ordered a year before by her OBGYN. She was healthy, her periods were very regular, and all of her testing was normal. She kept asking her OBGYN for a referral to a fertility doctor, and she kept hearing the same thing over and over. Well, you're just young, keep trying, I'm sure it will happen. Finally, after 2 years of this, she asked her doctor who to go see, and they told her the same thing, just keep trying longer. At least at this time, that was a huge red flag, and so she called and scheduled an appointment to come and see me. And when we saw each other, we went through the entire evaluation, talked about her medical history, I reviewed all of the testing, everything was done appropriately except a semen analysis. That's right, her partner hadn't been tested at all. And guess what? It turns out that he had no sperm on the semen analysis. They thought it must be an error, so we repeated the sample. But it turns out he actually has a birth defect, known as a congenital bilateral absence of the vas deferens. He's a carrier for cystic fibrosis, also something that he didn't know. And one thing that can be common in carriers of cystic fibrosis is being born without vas deferens. This is part of the connecting tube that connects the testes to the penis, meaning he was not having a transport tube to get the sperm into the ejaculated sample. Lucky for them, he still made sperm. So his hormones were fine, he was able to make sperm, but there was no way to get it from an ejaculated sample. This means we had to go into the testes directly and do an aspiration in order to get the sperm, and because you can't get very much sperm, you have to do IVF. After 2 years of being told, you're young, it will happen, just keep trying, this couple had to do IVF, and they had to do multiple rounds of IVF, along with a sperm extraction. This is just an extreme that sometimes people say things that are really dismissive, or they make a lot of assumptions based on your health or your age. That is just not the case. This patient now, luckily, they have multiple children and things have worked out fine, but she's always been such a huge advocate that you should be able to get fertility testing done anytime that you want it. She always tells me in her gut she knew that something was wrong, and she's just so upset at herself that she didn't get testing earlier, because maybe her journey would have been a little bit easier and they wouldn't have had to wait so long or feel left behind your peer group because they weren't conceiving and felt like a failure all of those months where there was zero chance they could have gotten pregnant. I think this just reiterates the point that it's okay to ask for testing beforehand. If you feel in your gut or you just want the data, maybe you're a little bit controlling like I am, that you don't have to wait any set amount of time. And again, if the worst case scenario is that you then just keep trying because everything was normal, that's not the worst case to be in. Being proactive doesn't mean that you're impatient, it just means that you care about being informed. I also like to say, what is normal? Well, if you're around age 30, your chance of getting pregnant per month is going to be a little under 20% per month. Even though we say infertility is defined as trying for 1 year without getting pregnant, most people will be pregnant, about 70%, in those first 6 months. So if you're not pregnant by 6 months, your chance of getting pregnant in the next 6 months does decrease. If you've been trying to get pregnant, though, for a year and you've not had success, you now have a 4 to 5% chance of getting pregnant per month. And if you've been trying for 2 years and you've not had success, that number drops to 2 to 3%, even if all of your testing is normal. So once you're falling off the curve, it does warrant an evaluation and intervention if having a kid is a life goal. And those numbers are all a little bit harsher if we're older. If you're starting to try for your family for the first time and you're age 35, you've got a 12% chance per month. And if you're 38 or older, it's actually 5% chance per month. So time is really important as we get older. Well, that brings us to part 3, equipping you with what you can do about this and what should you do. I first think that it's really important to take a moment to think about your own cycle and your menstrual history. Write it down, because when you see the doctor, I know it gets overwhelming and every question you have just leaves your mind. So how long have you been trying? How are your cycles? How many days apart? How long do they last? Are they painful? Are you tracking? What are you using to track? Is it just an app? Are you using an OPK, VBT, cervical mucus, which we will cover all of those. But what are you using and what is it telling you? Do you know that you're ovulating? How long is your luteal phase? All of this information is really important. In addition to, do you have any medical problems or any weird medical history? Or what about anybody in your family with infertility? There's no reason to go into this appointment unprepared. So know your story ahead of time. Number 2, know your goals. Are you trying to get pregnant right now? Are you wanting to get pregnant in the future? Are you not sure if you want kids? Are you considering freezing your eggs? I counsel patients different in all of these scenarios. And I think it's really important to know there's no right or wrong answer. It's just about what's right for you, and only you know that. So take a moment to think about what your goals are and what your perfect world would be like. I know that fertility and the journey to parenthood is not perfect. Life is dynamic and it throws things at us. We might change our mind, but I can counsel you the best if I know what your perfect looks like, because we might as well try to achieve that. Number 3 is know what testing you're getting and know what you want. Again, to put it shortly, I classify this as a semen analysis, blood work to look at ovarian reserve and some basic hormones, an ultrasound, and an anatomical evaluation to look at the inside of your uterus and your tubes. That's the basic evaluation for testing. With this in mind, ask a few follow-up questions. What does this mean for me? Is this normal for my age? What would you do in my situation? A lot of times doctors have different styles, and they may be somebody who's just presenting you information. I like to interpret that information and say, this makes me think, based on your goal, I would recommend XYZ. There's a big misconception that every fertility doctor is just going to push IVF, and that's not the case. Although sometimes IVF is the answer. Like in my patient who had no sperm in his semen sample, there was no other option for them, and doing testing earlier would have allowed them to start that journey on a faster timeline. So understand that we're just trying to get data so that you can be the most informed person along your family planning journey. So specifically ask, is my AMH or my antral follicle count, are these normal for my age? What does this testing tell you about my fertility? Do you see anything here that would make it hard for me to get pregnant? And what would you recommend that I do? Remember that fertility testing is just information and planning. It is not going to be something that you have to act on. It's just allowing you to be in the position to make the best decisions for you. That being said, if you're trying to get pregnant and you are having difficulties, please don't be scared of coming to the fertility doctor, and please don't delay getting that appointment. I've never had one patient in my office who said, gosh, I wish I didn't have testing done so early. I wish I'd waited longer. Time is your most valuable commodity, and use it wisely by getting yourself information about your own body and your fertility journey. Thank you so much for listening. I appreciate your support on the As a Woman podcast. And until next time, thank you, friends. Thank you for listening to the As a Woman podcast. Please consider subscribing, sharing, and leaving a review so that other women can find their formula for health. For more on fertility, hormones, and reproductive health, follow me at Natalie Crawford MD or visit nataliecrawfordmd.com, because knowledge is power, and your health deserves a formula made just for you as a woman.